Okay, here we go. This is hopefully our last part of this lot of material with chemotherapy and how it works. Anyway, so our hormonal anti-cancer drugs for prostate cancer. We have a drug called flutamide. It's an androgen receptor blocker. Is used in combination with the GnRH agonist. And this one is only used to treat prostate cancer. Prevents cancer cells from undergoing increased stimulation during the initial phase of the GnRH therapy, blocking the effects of the adrenal androgens on prostate cells. This one, because of what it does in blocking androgen receptor, it has reduced libido. So it reduced sex drive in males, in diminished testosterone. This is what makes them male. They have erectile dysfunction, gynecomastia, where they'll have larger breasts, decreased muscle mass, and decreased bone mass. A lot of males do not like this drug for that reason, as you can well figure that one out. And then we have a biologic response modifier is our interferon alpha. It benefits cancer patients by enhancing our immune responses and suppressing cancer cell proliferation. And we know that there's so many different parts of chemotherapy that reduce our immune responses. So interferon alpha is very, very, very good entity along with chemotherapy. Targeted anti-cancer drugs are designed to bind with specific molecules that drive tumor growth. If target molecules are found only on cancer cells, then targeted drugs should be able to arrest the tumor growth while causing little or no injury to normal cells. But unfortunately, most targeted drugs still cause serious adverse effects. That's what we're trying. The CD20 antigen is a molecule present in the cell membrane of normal malignant B lymphocytes. And our Ridumimab, again, we call this one RMAB, is a monoclonal antibody that binds with their CD20 and initiates apoptosis plus a lethal immune attack on B cells. The drug is indicated only for B cell non-Hodgkin's lymphoma because we know B cells are good. Why would we want to attack them? But the B cells are not good proliferation when they're diseased or sick and they act like cancer. So that's why that specific one will attack the B lymphocytes when they're diseased. Imatinib is highly specific competitive inhibitor of BCR-ABL tyrosine kinase, and this one has been identified as a chronic myeloid leukemia, or CML. It produces an abnormal, continuously active enzyme that activates regulatory proteins, which in turn inhibits apoptosis and stimulates excessive cell proliferation. It can be considered the model of a successful targeted anti-cancer drug, being both highly effective and well tolerated. This drug is the current standard of care for CML. And then we need to talk about extravasation, and that's where an anti-neoplastic drug will leak out at the IV place into surrounding tissue. It can result in permanent damage and actually loss of limb. To nerves, tendons, muscles, and again, loss of limbs. A lot of times they have to have skin grafting or amputations. I mean, this is serious stuff. When we say toxic, we're talking about poisons that we're dumping in these patients to kill the disease of cancer. Prevention, and I bolded it, is essential. Continuous monitoring of the IV site is very essential. It has to be monitored. And have, usually it's a 1-to-1 or 1-to-2 with the nurse. If it's suspected ever, you stop the IV fusion immediately, but do not remove the IV. Don't remove it, because in removing it, you can cause all kinds of problems in getting it out. If you can, aspirate the remaining drug or blood from the tube you've got gloves on, into another syringe. Follow the instructions for giving the appropriate antidote. There's going to be an antidote that stops it through the existing IV tube, and then remove the catheter. Some antidotes are not given through the IV catheter, they're given some other way. So with most drugs, you're going to stop it, and you're going to remove the IV. Not with chemotherapy. You're going to stop it and aspirate the remaining drug, but we have to give the antidote first before we give them any more, and of course we're going to get a different IV site. During the care of patient receiving these drugs. Special precautions may be implemented depending on facility. Again, we have to pull up the policy. Double flushing of bodily fluids in the commode if we're putting something down the toilet. Special hampers for disposal of all objects that contact the patient's body fluids. Personal protective equipment for the person giving the medication. And there's all kinds of special concerns if the chemotherapy liquid is spilled somewhere. We don't just wipe it up with our bare hands. Follow specific administration guidelines for each anti-neoplastic drug. Assess baseline blood counts always, always, always before giving any anti-neoplastic drug, because we know it's going to lower the counts. So we can kill these people if we don't look at what their baseline is. What is their hemoglobin and hematocrit, the oxygen carrying capacity of the blood? What is their neutrophil, their white blood count? Because we know the anti-neoplastic drugs are going to lower it. Okay. Our alkylating drugs, we're going to monitor for expected effects of bone marrow suppression, expect nausea, vomiting, diarrhea, and GI inflammation. Hydration, very important to prevent nephrotoxicity. Report any ringing or roaring in the ears, possible ototoxicity. Peripheral neuropathies may occur, tingling, numbness, pain in the extremities, especially the feet. Usually it's the feet before the hands. Cytotoxic antibiotics expect bone marrow suppression, nausea, vomiting, diarrhea, again, stomatitis. We need to monitor their pulmonary status. They can get fluid in their lungs. Monitor for nephrotoxicity, that's the kidney, liver toxicity, the cardiovascular status. Danurubicin may turn also the urine to a reddish color. So again, we have to alert the patient, or they're going to think, oh no, now I've got cancer in my gut, if they have it somewhere else. And danurubicin is the one that's almost identical to doxorubicin. In general, we're going to monitor closely for any anaphylaxis. So we need to know our epinephrine, antihistamines, anti-inflammatory drugs on hand. Monitor closely for complications associated with that bone marrow suppression, anemia, thrombocytopenia, and neutropenia. Cytoprotective drugs may be used to reduce toxicities. IV amifostine is to reduce renal toxicity associated with cisplatin. I think we already talked about that a little bit. IV or oral allopurinol to reduce hyperuricemia, and that'll save the kidneys if there's too much uric acid buildup in the blood. We're going to monitor for oncologic. These are oncologic, meaning a cancer patient emergency, such as infections, pulmonary toxicity, because if we wipe their lungs out, they're not going to be breathing. Allergic reactions. The gut can bleed so much, and it can be so toxic to the gut that they can have ulcers, bleeding there or anywhere else. Metabolic aberrations, bowel irritability with diarrhea, renal, liver, cardiac toxicity. We made it. Okay, you have 5 different sections. The 4 are much bigger than this last one. For chemotherapy, they are in a class, in many classes of their own. You really, really need to know the toxicities of what they do. And I want you to know the different cell-specific drugs and what group attacks which cell in the cycle, which cell, whether it's a resting stage, the mitotic phase, the synthesis phase, so forth and so on. Alrighty, I hope you all have a great day and talk to you soon.